It begins almost imperceptibly, a physical reflex honed by decades of social conditioning and the subconscious pursuit of momentary comfort, occurring the instant we settle into a chair at a dining table, a desk, or in the waiting room of a doctor's office. We shift our weight, lift one leg, and drape it over the other, locking the knee in a position that feels secure, grounded, and professionally acceptable. For millions of people, particularly those working in sedentary environments or enjoying their retirement years, sitting with crossed legs is not merely a random orientation of limbs, but a default physical state. It is a posture adopted without conscious thought, serving as a temporary relief for the lower back or a mechanism to retain body heat in cold environments. However, beneath this veneer of relaxation and social propriety lies a complex physiological disruption that, over time, wages a silent war against the structural integrity of the human body. While the mind perceives a state of rest, the anatomy below the waist is subjected to a cascade of mechanical stress. The act of crossing one's legs acts as a slow-acting poison to the musculoskeletal and circulatory systems, specifically targeting the delicate mechanics of the knee joints and the intricate network of veins responsible for returning blood to the heart. To truly understand the gravity of this silent enemy, one must look beyond the surface level of stiffness or fleeting discomfort and delve into the biomechanical chain reaction that occurs the moment the thighs overlap, creating a convergence of pressure, torque, and misalignment that accelerates aging and invites pathology. To dismantle this habit, one must first understand why the human body craves it so intensely. If the posture is inherently damaging, why does the brain interpret it as comfortable? The answer lies in the intersection of biological laziness and the ergonomic failure of modern furniture. Biologically, the human body is designed for dynamic movement, not for static endurance in a seated position. When we sit on standard chairs, which are often too deep, too soft, or lack adequate lumbar support, the core muscles of the trunk and the erector spiny muscles of the back must work tirelessly to maintain an upright posture against gravity. This constant muscular engagement leads to fatigue. In an effort to conserve energy and escape this muscular exhaustion, the body seeks a mechanical shortcut. By crossing one leg over the other, particularly in the knee-over-knee position, we create a passive locking mechanism. The friction between the thighs and the interlocking of the heavy leg bones create a stable tripod base that locks the pelvis in place, preventing the torso from swaying. This allows the core muscles to disengage and shut off, transferring the burden of stability from the muscles to the passive structures of the body, the ligaments, the joint capsules, and the bones. Therefore, the sensation of comfort we experience is actually the sensation of our muscles abandoning their duty, leaving the joints to bear the full, unbuffered weight of our posture. This is a dangerous trade-off, exchanging immediate muscular relief for long-term articular erosion. Furthermore, this physical compulsion is reinforced by a lifetime of psychological and social programming. From a young age, particularly in the case of women, the act of keeping legs together or crossed is drilled into the psyche as a hallmark of modesty, etiquette, and refinement. Sitting with feet planted firmly apart on the ground is often subconsciously categorized as exposed or unladylike. Conversely, for men, the figure-4 cross, resting the ankle on the opposite knee, is often adopted as a display of territorial dominance or casual confidence. These silent societal rules weave themselves into our proprioception, the body's sense of its own position in space, to the point where sitting in an anatomically neutral position feels wrong, vulnerable, or socially awkward. Thus, the habit is sustained not just by the search for physical stability, but by a deep-seated desire to conform to behavioral norms, making the practice exceptionally difficult to break even when the physical consequences begin to manifest. The primary victim of this convergence of muscle fatigue and social habit is the knee joint itself, a marvel of biological engineering that is being forced to function against its design. The knee is classified as a hinge joint akin to the hardware that allows a door to swing open and shut. It is optimized for flexion and extension, bending and straightening along a single plane. It is not designed to withstand significant rotational forces or lateral pressure. However, the moment one leg is slung over the other, the top knee is subjected to a force torque that it is ill-equipped to handle. While the thigh is fixed in position by the weight of the other leg, gravity continues to pull the foot and calf of the top leg downward. This creates a twisting motion, a rotational torque that travels up the tibia and assaults the knee joint. The collateral ligaments, the medial collateral ligament, MCL, on the inside and the lateral collateral ligament, LCL, on the outside, act as the biological cables that hold the joint together. In a cross position, these cables are stretched asymmetrically. One side is pulled taut to its limit while the other is compressed. When this asymmetrical tension is maintained for hours a day, over decades, the ligaments undergo a process of plastic deformation. They lose their tensile strength and elasticity, much like an overstretched rubber band that never quite snaps back to its original shape. This leads to chronic joint laxity, a condition where the knee feels unstable or wobbly during movement, significantly increasing the risk of falls and injuries in older age when muscular reflexes are already slowed. Deeper within the joint, the consequences are even more severe for the meniscus and the articular cartilage. The meniscus consists of two C-shaped pads of fibrocartilage that act as shock absorbers between the thigh bone, femur, and the shin bone, tibia. In a neutral sitting position, the weight of the thigh is distributed relatively evenly across these pads. However, the cross-leg posture introduces what is known as varus or valgus stress, forces that bend the joint inward or outward. This shifts the point of contact, focusing the pressure onto a small, specific area of the cartilage rather than dispersing it. For an older adult, whose cartilage has naturally thinned and lost water content over time, this concentrated pressure is akin to driving a wedge into a cracking stone. It creates microtraumas and hairline fractures in the cartilage surface, accelerating the wear and tear process known as osteoarthritis. It is not a sudden injury, but a gradual grinding down of the protective layers until the underlying bone is exposed. Furthermore, this static compression disrupts the nutritional supply to the knee. Unlike other tissues, cartilage does not have a direct blood supply. It relies on the sponge effect, the rhythmic compression and release that occurs during walking, to suck in nutrient-rich synovial fluid and expel waste products. By keeping the knee locked in a twisted, compressed state for extended periods, we effectively starve the cartilage of its nutrients, suffocating the cells and rendering them unable to repair the daily microscopic damage, thereby fast-tracking the journey toward chronic pain and immobility. While the degradation of the cartilage is a slow, abrasive process that manifests over years, the assault on the body's circulatory system is immediate and profound, occurring the very instant the legs are crossed. To fully grasp the severity of this impact, one must appreciate the Herculean task the venous system performs every moment of our lives. Unlike arteries, which benefit from the powerful, rhythmic thrust of the heart to propel oxygenated blood downward, the veins of the lower extremities face a far more difficult challenge. They must transport deoxygenated blood upward against the relentless pull of gravity to return it to the lungs for reoxygenation. This anti-gravity mechanism relies heavily on the calf muscle pump, which squeezes the deep veins during movement and a series of delicate, one-way valves that prevent the blood from flowing backward. When we sit with our legs crossed, we actively sabotage this sophisticated hydraulic system. The position creates a physical blockade, a literal kink in the hose, particularly affecting the popliteal vein located behind the knee and the femoral vein in the thigh. The weight of the top leg pressing down on the bottom leg acts as a tourniquet, narrowing the vessel's diameter and significantly increasing the resistance against which the blood must flow. The immediate consequence of this obstruction is a phenomenon known as venous stasis, where blood flow decelerates and begins to pool in the lower legs and ankles. This stagnation creates a pressure buildup within the vein walls, forcing them to expand beyond their natural elasticity. For a young individual with resilient tissues, the veins may bounce back once the legs are uncrossed. However, for the aging population, whose venous walls have already lost collagen and elastin, this repeated distension causes permanent damage. The valves, stretched apart by the widening vein, can no longer close properly, leading to venous insufficiency. This internal failure often manifests externally as spider veins, fine, web-like discolorations, and, more aggressively, as varicose veins. These bulging, twisted, rope-like vessels are not merely a cosmetic concern causing self-consciousness. They're a sign of profound circulatory distress. They are frequently accompanied by a sensation of heaviness, throbbing pain, and an insistent itching that can disrupt sleep and lower the quality of life. The leg, deprived of efficient drainage, retains fluid, leading to edema, the swollen ankles that make wearing shoes uncomfortable by the end of the day. However, the cosmetic and discomforting aspects of venous insufficiency pale in comparison to the life-threatening specter of deep vein thrombosis, DVT. While sitting cross-legged is rarely the sole cause of a blood clot in a healthy, active person, it becomes a potent catalyst when combined with other risk factors common in the elderly, such as dehydration, a sedentary lifestyle, or underlying cardiovascular conditions. When blood is trapped in the lower legs due to the compressive force of the cross posture, it thickens and coagulates. If a thrombus or blood clot forms in the deep veins, it creates a ticking time bomb within the body. The gravest danger arises when such a clot dislodges and travels through the bloodstream to the lungs, causing a pulmonary embolism, a catastrophic blockage of the pulmonary arteries that could be fatal within minutes. This grim reality highlights that the habit of crossing legs is not just a matter of posture, but a potential trigger for a medical emergency, turning a moment of seated relaxation into a critical health risk. The circulatory repercussions of this habit extend beyond the local veins of the legs to affect the systemic operation of the cardiovascular system, specifically regarding blood pressure. Clinical studies have repeatedly demonstrated that crossing the legs at the knee causes a temporary but significant spike in both systolic and diastolic blood pressure. This physiological response is triggered by two primary mechanisms. First, the physical compression of the large veins in the legs forces a volume of blood that would normally pool in the lower extremities back into the central circulation, increasing the volume of blood returning to the heart and thus the volume pumped out with each beat. Second, the isometric contraction of the leg muscles required to maintain the cross position increases peripheral vascular resistance. For a person with a healthy heart, this transient rise is manageable. But for an older adult already managing hypertension or heart failure, these frequent, self-inflicted spikes impose an unnecessary and dangerous workload on an already stressed heart. It also complicates medical diagnoses. White coat hypertension can be exacerbated simply by a patient crossing their legs in the waiting room or during a measurement, leading to inaccurate readings and potentially inappropriate medication adjustments. Parallel to the circulatory system runs the body's electrical wiring, the nervous system, which is equally vulnerable to the compressive forces of crossed legs. The most frequent casualty in this domain is the peroneal nerve, a major branch of the sciatic nerve that winds around the side of the knee. Unlike many other nerves that are buried deep within protective muscle tissue, the peroneal nerve is superficial, sitting just beneath the skin and resting against the hard surface of the fibula bone. This anatomical positioning makes it exceptionally prone to injury. When the legs are crossed, particularly when the knee of the top leg presses firmly into the side of the bottom knee, the peroneal nerve is crushed between the two bony surfaces or against the external object like the opposite knee. This compression interrupts the electrochemical signals traveling from the brain to the lower leg and foot. The initial warning sign of this neural blockade is the familiar sensation of paresthesia, the pins and needles or tingling sensation that signals the leg has fallen asleep. Most people dismiss this as a minor annoyance, shaking the leg until feeling returns. However, this sensation is actually a cry of distress from the nerve fibers, indicating ischemia, lack of blood flow, and mechanical deformation. When this compression becomes a chronic habit, the nerve may sustain damage that does not resolve simply by standing up. Long-term, repetitive trauma to the peroneal nerve can lead to peroneal neuropathy or palsy. The most debilitating symptom of this condition is foot drop, a profound weakness in the muscles that lift the front part of the foot. An individual with foot drop cannot dorsiflex their ankle properly. Their toes drag on the ground when they walk. For an elderly person, foot drop is a catastrophic impairment. It forces them to adopt a high-stepping gait to clear their toes from the floor, drastically destabilizing their balance and exponentially increasing the risk of tripping. Thus, the chain of causality is complete. A simple sitting habit compresses a nerve, which weakens the foot, which leads to a fall, which can result in a hip fracture, a sequence of events that often marks the end of independent living for seniors. This neurological impact underscores the fact that the comfort of crossing legs is an illusion, masking a direct threat to the body's ability to sense and navigate the world safely. While the neurological consequences are immediate and acute, the impact on the cardiovascular system is insidious and cumulative. When one leg is draped over the other, the body is subjected to a significant hemodynamic shift. This posture acts as a mechanical tourniquet, impeding the natural flow of blood from the lower extremities back to the heart. The immediate physiological response is a measurable spike in blood pressure. Clinical studies have demonstrated that crossing the legs at the knee can elevate systolic pressure significantly. For a healthy young adult, this temporary surge is negligible. However, for an older adult already managing hypertension or heart disease, these frequent, artificial spikes place unnecessary and dangerous strain on arterial walls that may already be fragile or hardened. Even more concerning than the pressure itself is the phenomenon of venous stasis, the pooling of blood in the veins. The crossed position compresses the popliteal vein behind the knee, creating a dam-like effect. Blood that should be cycling back to the heart to be reoxygenated instead stagnates in the lower legs. Over time, this pressure distends the vein valves, leading to the development of varicose veins, twisted, enlarged vessels that are not merely a cosmetic concern, but a source of chronic aching and heaviness. In the worst-case scenario, this stagnation creates the perfect breeding ground for a deep vein thrombosis, DVT. When blood ceases to flow dynamically, it begins to clot. A thrombus formed in the deep veins of the leg due to prolonged immobility and compression acts like a ticking time bomb. If this clot dislodges, it can travel through the bloodstream to the lungs, causing a pulmonary embolism, a life-threatening event that strikes with little warning. Thus, the habit of crossing legs transforms a moment of relaxation into a game of chance with the body's most vital circulatory mechanisms. Beyond the silent threats to nerves and vessels lies a more palpable architectural failure, the distortion of the musculoskeletal system. The human body is engineered for symmetry, yet crossing the legs is an act of forced asymmetry. When one leg crosses over the other, it acts as a lever that physically rotates the pelvis backward and tilts it laterally. This is not a passive adjustment. It creates a significant torque that travels up the kinetic chain of the spine. For the elderly, whose intervertebral discs have naturally lost hydration and elasticity over time, this torque is particularly damaging. The tilted pelvis flattens the natural lordotic curve of the lower back, forcing the lumbar spine into a rounded, unnatural position. This places uneven, crushing pressure on the spinal discs, specifically stressing the posterior walls of the discs, which can exacerbate existing issues like herniation or sciatica. It is a recipe for chronic lower back pain that no amount of medication can fully resolve if the mechanical cause remains uncorrected. Furthermore, the spine functions as a single continuous unit. A misalignment at the base inevitably forces a compensation at the top. To keep the eyes level with the horizon while the hips are tilted, the upper back and neck must twist in the opposite direction. This constant, low-grade torsion strains the muscles of the neck and shoulders, leading to tension headaches and cervical stiffness. Over years, This habit can accelerate the progression of osteoarthritis in the hips and spine. The cross-leg position essentially locks the body into a twisted state, eroding the structural stability required for standing tall and moving freely. The comfort of the moment is purchased at the cost of the body's long-term alignment and mobility. The cumulative evidence is undeniable. Crossing the legs is not merely a benign quirk of body language, but a sustained physiological assault on the aging body. For seniors whose physiological reserves are already diminished, this habit represents an unnecessary leak of vitality. However, understanding the mechanism of injury is the first step toward prevention. The solution requires a conscious reprogramming of decades-old muscle memory, shifting from passive constriction to active alignment. To reclaim their stability and circulation, seniors must adopt the 90-90 rule of ergonomic sitting. In this neutral position, the feet are placed flat on the floor, hip-width apart, creating a 90-degree angle at the knees and a 90-degree angle at the hips. This alignment distributes weight evenly across the sit bones, ischial tuberosities, instantly relieving the torque on the spine and opening the vascular floodgates for optimal blood flow. If the urge to cross legs feels overpowering due to habit or discomfort, crossing at the ankles rather than the knees is a safer compromise. This low cross position significantly reduces the strain on the pelvis and minimizes the compression of the popliteal vein. Ultimately, the best posture is a changing one. The golden rule for senior mobility is to break the static cycle every 30 minutes. Standing up, stretching, or taking a short walk acts as a reset button for the body, pumping stagnant blood back to the heart and resetting the nerves. Uncrossing the legs is more than a physical adjustment. It is a commitment to longevity. By planting both feet firmly on the ground, an individual does not just improve their posture. They solidify their foundation, reducing the risk of falls and ensuring that they remain standing strong for years to come.